Thank you. That's very good. I appreciate you doing your research. I'm Susan Malinowski, and my accent gives it away. I don't speak the Queen's English. I speak American English, so I hope you can understand me. I'm from the Detroit area, and I want to talk to you today about centrifuged intravitreal triamcinolone acetonide, which I call Slurry Kenalog. This is an easy, quick, and inexpensive alternative to long-term steroid delivery. We have different forms of it around the world. I've been speaking at the different receptions that we've had at this wonderful meeting, and I've been told that most commonly Kenacort is used in this part of the world and the Middle East. We know it as Kenalog in the United States. We also have Triessence, which is also triamcinolone acetonide in a preservative-free form. But whatever form you use, it is a suspension, and the depot is where the drug is. If you can give a longer depot, you can increase the duration of effect. How do we make Slurry Kenalog? We make it by using the centrifuge. Dr. Mike Ober and Associates in 2013 elegantly described the technique, and I have this available on YouTube and iTunes simply by searching Slurry Kenalog. It's also available on the movie section of the EVRS. But let me briefly go through how to make Slurry Kenalog or Slurry Kenacort. First of all, you gotta get a centrifuge, and I know you have eBay here in Europe. In the United States, a used centrifuge costs less than 60 euros. A used one is just fine. You draw up the entire vial of the triamcinolone acetonide that you are using. Draw the whole thing up. Cut off the plunger, cut off the flanges, and then centrifuge it for 30 seconds. If your centrifuge is not self-leveling, flip it 180 degrees so you can get a nice even precipitate in the syringe. Place a second plunger behind the first one that you've severed. Place a 30 gauge needle. Yes, a 30 gauge works just fine. Make sure it's nice and tight for when you inject. And voila, you have created Slurry Kenalog. So how well does Slurry Kenalog work? I've been using this technique for 7.5 years. The minimum follow-up had to be 9 months since the last injection, and patients were seen every 2 to 3 months to see how they were doing. Macular edema was treated from a variety of causes. Most of these patients did have diabetes. Patients had prior vitrectomies, controlled glaucoma, and none of these patients were treatment naive. At first, when I started using this technique, these were the worst of the worst, patients who did not respond to any other therapies. But again, all patients have been previously treated. Some cannot afford other treatments. Some cannot find the time to come in frequently. This was an objective assessment of the duration given the retrospective nature of this review, and I looked for the recurrence of cystoid macular edema by OCT. There were 257 injections given in 52 patients, 63 eyes, and the average follow-up per eye was over 3 years. How does it work? A single injection lasts an average of 8.4 months. The range was from 2 to 24 months. Again, a single injection, 8.4 months. 20% of the patients had previously undergone vitrectomy, and in those patients, as expected, the duration was slightly less, but still very acceptable at under 6 months. And if we look at the patients who had never had a vitrectomy, 9 months was the average. If we look at the cause of the macular edema, again, the majority had diabetes, but I did use this for a number of other indications with variable responses, but again, still very respectable, anywhere from under 5 months to 11 months. But we're all concerned, of course, about steroids, right? If you take too many, you might end up looking like this guy. So what are the bad things that happened with Slurry Kenalog when I'm injecting such a large amount of steroid into the eye? There were no cases of infectious endophthalmitis, and there was 1 case of sterile inflammation in the study time frame, which resolved without sequelae, and the drug still worked. How about cataract development? Well, of course, these patients developed cataract. 90% had progression of their cataracts. 73% underwent cataract surgery. What about steroid response? It wasn't as bad as I thought it might be. I defined steroid response as a change of 10 from baseline, very conservative. The average intraocular pressure at the time of steroid response was 29 in 21% of patients. 17% of patients required some type of therapy, and only 1 patient required a trabeculectomy during the entire time frame. The average time to steroid response, 3.7 months. So how does Slurry Kenalog compare to the dexamethasone implant and the 2 forms of the fluocinolone acetonide implants? Let's have a quick look. In terms of cataract development, about 3/4, which is on par with the other preparations. 21% rate of steroid response, which is on par with most of them and at the lower end. The need for glaucoma medications actually appears to be less than the other 3 preparations, but of course this is a retrospective, non-controlled sample. The need for incisional glaucoma surgery is at the low end, and again, the efficacy from a single injection, 8.4 months. And of course, as a worldwide retina community, we are all concerned about cost. Given an expected less than 3 injections in 2 years, Slurry Kenalog would cost about 23 euros. So in summary, Slurry Kenalog lasts an average of 8.4 months from a single injection. There were no serious adverse events during this time. I think that the side effect profile is acceptable and it's cost effective. As I said, I come from Detroit. I don't know if Detroit is the automobile capital of the world anymore, but I think it's the Slurry Kenalog capital of the world. Thank you.
2 questions. One is you're dealing with a high concentration like Jonas did some years before, but I think its limit was 20 milligrams, and you are with 40 milligrams now.
Correct.
And that possibly extends the duration. But what does the centrifugation process make in comparison just to allow the Kenalog to, when you wait and stand and remove all the surplus and fluid and have the concentrated powder, as I would call it, what is the difference with centrifugation for 30 seconds?
So the centrifugation is 1 minute. And the difference is that with the sedimentation method, which has been reported, to get the same amount of steroid, you have to leave it hanging for almost a whole day. In the office, when I use this and I have a patient who requires Slurry Kenalog, I tell my technician I need a slurry. She goes down the hall, she spins it for a minute, and I have it. So at least in theory, not only can you use it on the fly and not have to prepare it a day ahead of time, but I think that if you have a medication that's sitting out for a day, you increase your risk of infection. So it's the speed and the availability.
This doesn't change anything to the estimation itself.
I don't understand the question, I'm sorry.
But there's no change concerning the concentrated medication at all, compared to just let it wait until it settles down. And you have possibly a more definite concentration than comparison to just waiting for half an hour or so.
Well, you have to wait longer than a half an hour. This actually has been published by other authors. And we're still working on the exact amount in multiple samples, but this gives you approximately 28 milligrams. So it's not a full 40. Some of it is actually expelled in the supernatant.
Thank you.
You're welcome.
I have a quick question for you.
Yes.
I mean, I had a problem as well. I mean, it blocks sometimes the needle. When you have such a concentration of particles, blockage of the needle is a real nuisance.
So as I said, I've been doing this technique for 7.5 years. I always use a 30 gauge. I think part of it is that you're making it on the fly. It doesn't sit. If you allow it to sit, then I think it starts to solidify, and then you cannot get it through a 30 gauge. But I always use a 30 gauge. You have to attach it firmly, but it always goes through. I've not had any problems. And again, I use it right away.
Yeah.
Just a quick question. Is it an on-label procedure?
This is an off-label procedure, absolutely, yes.
Okay, we carry on then.